Good evening, everyone. It gives me great pleasure to welcome you all to today's webinar. I will start the proceedings with a brief introduction about FACE-ME. FACE-ME, as you know, Families Alliance on Mental Illness India, was founded by Dr. Nirmala Srinivasan. It operates at a pan-India level to ensure optimal scope for the delivery of psychiatric services provided by the government, particularly those in urban metros and cities. We operate as a community of family volunteers working for the wellness, security, and dignity of our loved ones who are under treatment for mental illness. We use family in an inclusive sense of all members. Today's topic on genes and heredity in schizophrenia. I would like to introduce our speaker for the day. And one minute, I'm sorry. Our speaker for the day, Dr. Virupaksha. I know him personally as he is the treating psychiatrist for my brother. And so I've had many interactions with him, and gives me great pleasure to introduce him here today. Welcome, Dr. Virupaksha, to our session today, and thanks for agreeing to speak to our members. A brief introduction to Dr. Virupaksha here. He did his MBBS from the Mysore Medical College and his DPM from NIMHANS, Bangalore. He's a gold medalist from there. And he also did his MD in psychiatry from NIMHANS. He also has an advanced certification training by CISMU, UNDSS, United Nations. He is into training and research and fMRI image analysis from NIMHANS. Also, that training also he has undergone. His professional experience, the latest has been that he was the professor and head of the Department of Psychiatry at Ramaiah Medical College. Presently, he is the professor and head Department of Psychiatry as BGS Medical College Hospital, Nagarur, Bangalore. His special areas of interest are schizophrenia, addiction, transgender mental health, and neuroimaging. His special skills are in clinical assessment and treatment of all psychiatric disorders, psychotherapy, crisis management, communication and leadership, research and research guidance. He has several awards and recognitions to his credit. I'll just read out a couple of them. Dr. D.L.N. Murthy Rao Award, Gold Medal from at NIMHANS in 2011. Dr. D.S. Raju Memorial Award, Indian Psychiatric Society, South Zone 2011. And Leadership Development Program, Ramaiah Medical College and People Business 2023. Research Achiever Award in Ramaiah Medical College 2024. These are just to mention a couple of them. Now I would like to ask Dr. Virupaksha to kindly take this forward.
Yeah, thank you so much, madam, for that kind introduction. Good evening, everyone. I think I should thank FaceMe and everyone, including Sindhuja, Nirmala Srinivasan, madam, for giving me this opportunity to interact with you all. It always gives me a pleasure to interact with people who are interested to understand about mental health issues in general and schizophrenia in particular. This topic is something which is quite complex. And in fact, within the psychiatry circle, when we talk about genetics, heritability of certain psychiatric disorders, be it with our students, postgraduates, or amongst us, this is a topic which is very, very complex. So I will try my best to simplify it. I'll not get into very technical aspects of it because I think it's something which is not relevant. That's not very relevant. At the same time, even though the focus of today's discussion would be genes and hereditary of schizophrenia, I would also take this opportunity if there are any questions about psychiatry, about treatment. Please use this opportunity to ask me. You can use the chat box to put your questions. Or also, if you feel that, okay, there is a question that probably it cannot wait till the end of the talk or something like that, you can always interrupt me in between and ask the questions. I think we have sufficient amount of time. So if there are any questions, any this thing, because psychiatry is one of the most misunderstood or not understood medical specialty. Not just from the general public, it is also from the healthcare professionals themselves. So in that sense, I think we'll use this opportunity to understand and learn from each other. There is a tremendous amount of experience, both in from all aspects. So I think that is something that we can use. I have tried to make a presentation. So the presentation is only generic in nature. At the same time, if there are any specific things, feel free to ask. It is not restricted to the content in the presentation. So I will be taking probably around 30 minutes for the presentation. And whatever questions we have, we will try to make it interactive. Please feel free to ask anything in between. So can one of you please confirm whether you can see the...
Yeah, we can see it, doctor.
Okay. Trying to just minimize the video. Yeah. Okay. Is it clear? Am I audible?
Yes, doctor, you're on.
Yes, sir. Yes.
Yeah, yeah. So one of the reason why schizophrenia becomes a very important factor, uh, and for us to understand about schizophrenia is whenever someone looks at or hears about a psychiatric disorder, one of the common things that comes to anyone's mind is schizophrenia, because it is almost like a synonym of psychiatry, even though there are so many other psychiatric disorders that we treat. This is considered as one of the most severe and most difficult to treat. And it is also one of the... Okay. So it is also one of the most studied psychiatric disorder. So there are lots of evidences about genes and heredity. Like I mentioned, I will try to run it in a very basic sense. If there are any questions, please go ahead and ask me. I would like to show this video. This is nothing to do with the psychiatry. This is nothing to do with schizophrenia, but it helps us to understand how complex the brain is. One of the reasons why psychiatric disorders are not well understood in terms of the symptoms and pathology, and more also about genetics and heritability, is because it's very, very complex. And it is also the reason why many a times when patients come and ask us, why do we have it, or how did this happen? The answers are not very, very clear. And this is a longer video, but I will stop in between. This is a video of a nebula. How... So one of the reason why I have showed that video is to indicate that most of our galaxies or nebulas look like a very grayish area with lots of dots on it. But the more we get inside those things, there are millions and millions of stars which are completely undetectable through a normal eye, and these are all captured by very high power telescope. Similarly, when we started to understand psychiatric disorders as disorders of the brain, previously it was called as functional disorders. Now we know that they are not functional, they have complete biological explanation for each and every psychiatric disorder. So the more we are trying to dig deeper into it, the more we are finding out that it is much and much more complex than what it is. So this is just a pictorial representation of how difficult it is to understand the brain. It is not that simple. At the same time, over a period of time, we have come to a situation where at some point in time, when we realize that psychiatric disorders were just functional disorders without any major biological changes, now we know, just like how we changed from a flat earth to a round earth, even now there are some people who continue to think that the earth is flat and not a sphere. We have come to understand certain aspects of it, both, I would say, biological in terms of how is the structure of the brain, and then there is something called as a functional brain, functional magnetic resonance imaging or functional scans. How are they going to differentiate between a normal person and a person with psychiatric disorder? And when we dig deeper, then there is genetic aspects of it. So genetic aspects are considered as the one of the most complex to understand, because we have millions of genes which it is humanly impossible to try to check each and everything and link it to a particular disorder. So what we are trying to understand by using various genes or DNA profiling or chromosomes is to look at a much deeper aspects of the brain and understand how is that behaving. So if there is a family history of schizophrenia, what is it? What does that mean? If there is someone distant relative who has diagnosis of schizophrenia, how is it going to change? So this is a soldier who is trying to look through the wall without breaching the wall. This is the technology that the military is using. Similarly, the genes and the functional imaging gives us an indication of what is going to happen and what are the various aspects. Are we yet there to conclusively say? Not really, which I'll explain over a period of time. But this is the whole point of understanding genes and heredity. So if you look at any psychiatric disorder, and specifically schizophrenia, they are made by the fine interplay of an imbalance in certain what is called as a neurotransmitter. In this picture, you see that on the top, there is a normal neuron where there is a dopamine, which is a type of a chemical which is there in our brain. And then there are receptors which receives this chemical for transmission. Whereas in Parkinson's disease, which is a type of a neurological disorder, we see that the dopamine is very, very less. Because the dopamine is very, very less in Parkinson's disease, we give them dopamine enhancers or dopaminergic agents, we call it as. In schizophrenia, you can see that the amount of dopamine is significantly higher compared to Parkinson's. It is much more than Parkinson's. It is much more than the normal neuron. So there is too much of dopamine. And then that leads to a particular type of symptoms. That is the reason why you're using antipsychotics, we block dopamine. So why does all this happen? How is that a person, probably in the same family, someone is normal, someone has schizophrenia? How does that happen? That is the whole point of talking about genetic aspects of it, heredity aspects of it, because genes play a fine interplay of expression or non-expression of things. So within the family, if someone has a particular gene which makes them vulnerable to develop a particular disorder, then that get expressed. At the same time, if the gene is not very dominant, they might not get expressed. So one of the common question a lot of family members ask is, why me? Or why my son? Why my daughter? Why my wife? Why my spouse? That all boils down to something that we would probably not able to control, or which comes to the fine interplay of genetic, environmental factors, and so many factors leading into a particular disorder. So some of the neurotransmitters, like I said, which is determined by various genetic component, there are lots of studies about it. Like for example, acetylcholine in Alzheimer's disease, dopamine in schizophrenia, that is the focus of today's discussion. Serotonin in depression, norepinephrine in again depression, glutamate in seizures and overstimulation, including in mania. So what is gene? When we talk about gene, when we talk about heritability of a particular factor, what is it? In a very simplistic term, we all have cells in the body, and within the cells, there is a very complex mechanism of the nucleus. How do they use the energy? There are so many factors. Something that we need to focus upon is a chromosome, which we all have a pair of chromosomes. Women have X and X chromosome, men have X and Y chromosome. So within that chromosome is a finely knit structure of nucleotides, and a set of nucleotides are called as a gene or a DNA. So the DNA consists of various amino acids. Depending upon their structure, depending upon the constitution of that structure, each and every gene is coded, and they help us in building our body, making our body function normally, and also executing all properties normally. Sometimes the genes can get damaged. You might all have heard that when it is sunny, when there is a lot of sun, you don't have to go out without wearing the sunscreen or probably wearing a shade, because sunlight is considered to lead to genetic mutation. So similarly, as we age, a spontaneous genetic changes can happen. And sometimes if there is a genetic mutation in an adult and who goes on to have a child, sometimes these genetic variations can be transmitted to the child. So that is where heritability, the gene and all those things come, because they are transmitted from one generation to another generation, and sometimes they are transmitted across multiple generations. So the genetic aspect is not just in psychiatric disorders. You name any medical disorder or neurological disorder, genes play a major role in not just about probably having a disorder or a disease. It also plays a role in how a particular person behaves, how a particular person expresses certain symptoms, and including how a particular person responds to treatment. Because one of the common question a lot of times people get is, why is that this medication is not working for me? Why is that that person responded? We both have the same illness. That person responded to that medication. Why am I not responding? That all boils down to the what is called as a pharmacogenomics, which helps us to respond or not respond to a particular drug. So the emphasis here is, when we look at genes and heritability, we should not always be looking at, okay, is it the cause for a psychiatric disorder? Or is that what led some person to have a particular diagnosis? It is also very important to understand that that plays a major role over a period of time. So this is what determines what is going to happen. How is the person going to respond or not respond? How long the person is going to uh, probably continue with the treatment or the illness. So why these changes? Why is that the brain has to have certain changes? Why is that the symptoms or this thing can happen in any specific person. So that brings us to the question of the pathophysiology of how a particular disorder happens. And this is very important to understand before we get into the heritability factors of it. So imagine that there is a component of dry leaves or a dried this thing in a forest. What happens is after a particular amount of time, the dry and moist various components, like we just came out from summer, so there was a lot of risk of fire, dry environment and high combustibility. Whenever something is dry, that leads to high combustibility. What does that lead into? That leads into a component of friction. You know that the forest fire, how does it start? The friction leading into an external fire, leading into a forest fire, which is sometimes can be dangerous, which can probably burn hundreds and hundreds of acres of the forest. So I'm trying to draw a parallel between this example and the body and mind, where if there is a body and mind, you have a genetic vulnerability. Do anyone know that there is a genetic vulnerability? Most of the times we might never know unless we specifically test for it. So that is an inherent vulnerability that many of us carry. Many of us throughout our life might not even express that vulnerability, but sometimes when something happens, it might get unmasked. Along with the genetic vulnerability, which is completely internal in nature, there are social factors and then other factors. It could be family, it could be substance use, it could be interaction, it could be breakups, it could be financial issue, it could be 101 other factors. And these two things play a interaction. When there is a vulnerability, along with that you add the complexities of the social and other factors, leads to an interaction and sometimes imbalance in the receptors, leading into an equivalent of external fire, which is a substance use or any other disorder. We call it as comorbidity. One of the common factor that we sometimes we do not recognize is most of the times whenever there is a psychiatric disorder, there is also some other medical disorder or a neurological disorder, because there is also a genetic similarity between these things. There are lots of studies and evidences about it. I will not go into it. So these disorders with genetic vulnerability and the stressors or the social factors leads into development of schizophrenia. So you can understand here, it is not just because a person is existing, it doesn't mean that he will go on to develop a particular disorder. There are so many fine complex issues that has to come together for him to unmask his vulnerability. So there is a genetic predisposition, and then add the environmental factors leading into certain neurodevelopmental abnormalities, leading into brain dysfunction and improper balance of chemicals, like I said, dopamine, which is all determined by our genetic variation or a genetic expression, leading into psychosis. So then when we understand all these things, what is that the questions that come to our mind? So what's the risk? I will specifically mention about the risk of schizophrenia in various combinations. This is one of the complex and a common question that comes to all of our mind. If any of our family member has schizophrenia, what is the risk that I might develop? Do we have a particular number? The number is in percentages. And for your information, any general population, the risk is 1%. Any relationship with any family member or a distant relative who has schizophrenia as the diagnosis, the percentage increases, which I will specifically talk in a particular slide. And then the other question is, if it is heritable, if it is genetic in nature, should he or she get married? What I want to also emphasize here is we have through various studies, there are something called as a genome-wide studies, which look at so many millions of genes across our DNA. They have been able to identify hundreds of genes that are commonly seen in schizophrenia, but they only say that probably 30 to 40% of it is what is heritable. The 60% is not. So, if a person has schizophrenia, are we ethically correct to say that he or she should not get married? The answer is no, because we generally say a person, if he is on treatment, if the illness is not severe, they are completely fine to have all lifestyle and events that can happen. Then comes the question of, can a person with schizophrenia have a child? Again, this is something that I will explain with the next slide, which looks at the heritability and the transmissibility of it. Can they get educated? Can they have a job? Can they have normal life? Lot of clients, I'm sure that you have come across, I have during my last few years of the patients that I've seen in schizophrenia with all severities. I've seen so many people with first episode of schizophrenia or the second episode of schizophrenia or the multiple episodes of schizophrenia. If you are treating them normally, while on treatment, they can have completely normal life. Yes, they might require some amount of support, but they can have it. And majority of the times, the responses and all those things, even though they are something which is very, very different, but if you treat them optimally, most of the people, I'm using the word most of the people, can have normal routine. So this is the slide that I was talking about. Very important slide, and this has not changed much from the 1990s, which is still something which we follow. So the general population, the prevalence of schizophrenia is 1%. So that is the basic risk that we all have. So then comes, if at all any person who has a relative as per this relationship, like if someone has a first cousin, what is my risk? If I have a first cousin with schizophrenia or my uncle and aunt have schizophrenia, what is my risk? It is 2%. The risk almost doubles to 2%. Then comes the nephew and nieces, grandchildren, or half siblings. They are second degree relatives. Comes to anywhere between 4 to 6% of it. If parents have it, it is one of the parent, it is 6%. You need to understand the number that says 6% means if there are 100 people who have kids, there is only a possibility of 6 kids from that who can go on to develop schizophrenia. So that is 6%. If siblings, I will also explain one of the study that I did while I was in NIMHANS about the first degree relatives. They are called first degree relatives. If a sibling has schizophrenia, then there is a 9% chance. If your child has a schizophrenia, then there is a 13%. Fraternal twins and identical twins, we call it as. Fraternal twins means there are two eggs which are the this thing by two sperms, that is 17%. Identical twins is monozygotic, that is a single egg by a single sperm, and then they divide into identical twins, that is 48%. So probably if there is one slide that I want all of you to remember is this slide, because the identical twins, the risk is 48%. Rest everything is less than 10 almost. That means that there is only 1 in 10%, 10 times chance that anyone, even with a family member, even with the probably a relative with schizophrenia, can go on to develop it. So on the left extreme side, you can also see that there is an amount of genes that is shared. So if they are identical twins, they share 100% of the genes, and that is the reason why 48% can go on to develop. So even with 100% sharing of same genes, not 100% of the times the identical twin has schizophrenia. This is very, very important because people assume that the moment there is a person with schizophrenia in their family, everyone is at 100% risk, which is not true. Still, half of the identical twins might not develop schizophrenia because the genes may not get expressed there. In first degree relatives, only 50% of the genes, and that is the reason why you see a significant drop in the risk of developing schizophrenia. In second degree relatives, it is only 1/4, so you only see 4 to 5%. In third degree relatives, it is only 12.5%, so that is the reason why you see around 2%, 1 to 2% of it. So it is not true when people unnecessarily get panicky and stressed out, because the moment there is a diagnosis in the family, we tend to get very, very anxious. There are particular ways to handle this risk, how not to get into the risk, and all those things, which we will cover over a period of time. What is also important is, just because there is a genetic risk, just because there is an environmental risk, doesn't mean that the person goes on to develop psychosis. So in the first jar, you can see that there is a genetic vulnerability factor, but the person doesn't have any environmental factors. So, like for example, the person has a gene which makes him or her vulnerable to develop schizophrenia, but there is no stress, there is no substance use, there is no pressure, there is no trauma. The environment has been fine. Then they do not develop psychosis or schizophrenia. In the second one, if there is a genetic vulnerability and some amount of stress, yes, they might have some symptoms, but they do not get into having a syndromal diagnosis. When I call a syndromal diagnosis, that means that all symptoms are there to make a diagnosis. But over a period of time, when these two breathe together, there is a genetic risk, and the environmental factors also becomes too much that the person cannot handle. Then what we call as decompensation happens, unmasking of the genetic vulnerability happens, and the person goes on to develop psychosis. So if a person has a risk which is genetic in nature, or where there is a family history of psychosis or schizophrenia in the family, that person should be trained, should be protected from having any environmental vulnerability, because the moment you add that, there is a much higher chance of that person developing psychosis. And that is where understanding genes and heritability comes to play, because this knowledge makes people to have certain lifestyle changes, and the lifestyle changes prevents them from developing psychosis. Or there is also something called as uh, duration of untreated psychosis, or sometimes latency of expression of psychosis. That is all because of interplay between genetics and environmental factors. Hope I'm not very fast.
No, sir, I think they've unmuted themselves. That's it.
Okay,
Please
okay,
continue, sir. Thank you.
right. So that also brings us to the question of, if there is a genetic vulnerability without environmental factors, what do we do? What should we do? These people with any amount of genetic vulnerability, where there is a distance, because you take probably 5 generations, 10 generations, 15 generations in your own family, invariably you are going to have some genes from throughout your generation. So then we call them as having what is called as a high risk subject. So I was mentioning about the study that we did in NIMHANS. This study, we studied only people who are related to patients with schizophrenia. They are called high risk subjects. You can see that there is in the top column, there is a high risk subject. These are relatives, first degree relatives, siblings of patients with schizophrenia. You can see down there where I have marked it as red, the RT means the reaction time. So if I ask a question, what is the response time in people who are related to schizophrenia patients and people who are completely no linkage to anyone with schizophrenia in their family. You can see there that controls are people who have no relationship with anyone with schizophrenia. You can see the time in controls is much faster than high risk subjects. Both in RT0B, it's called as a reaction time, and RT2B is called as a reaction time to back. And ACC is the accuracy, ACC2B is the accuracy of to back. The accuracy of the controls is 95 compared to 87, which is lesser. Accuracy in 2B is 74 compared to 55, which is again lesser. What does this indicate? None of these high risk subjects are actually people with schizophrenia diagnosis. They were all people who had some distant link. When I say distant, first degree relatives with patients with schizophrenia. So this means that there is a vulnerability, but they are not psychotic. They are not diagnosed with schizophrenia. And these are the people who need that extra support, who need that lifestyle changes, not to get into substance use, not to get into any other problems which might unmask the genetic vulnerability. And this is also the same study where we check the cognitive function of various things. How is the concentration? How is the analyzing capacity and all those things? You can see on the right side, wherever I have put less than 0.001, that means that high risk subjects were doing a bit, I would say, less efficiently, less accurately compared to the controls who had no relationship with schizophrenia. This indicates that any relationship sometimes has the genetic vulnerability because we all share the genes, but that doesn't mean that we all are going to develop psychosis just because there is a relative, though that leads into the questions of what are the things that we need to understand. The evidences till now, even though like I mentioned, there are so many, at least 300 to 400 points of DNA or the genetic components or SNPs that we call it as have been linked to schizophrenia. At this point in time, it is not conclusive in nature. We cannot say just because a person comes with schizophrenia, I cannot be confidently saying that, okay, there is going to be heritability. Do not go ahead with education. Do not go ahead with marriage. Do not go ahead with relationship. Do not go ahead with work. The evidences are still not conclusive. There are hundreds and thousands of patients who have been studied, but we are in a preliminary stage to determine this is exactly the heritability. This is exactly the genes that are involved. The second one is, like I mentioned already, we need to be very, very careful about understanding the relationship of nature versus nurture. One of the common thing that happens is the moment there is a genetic vulnerability, we tend to panic, we tend to create more stress, which in fact can be counterproductive. So providing that nurture, providing that environmental factors which do not allow the decompensation is one of the best way to prevent the development of a syndromal disorder. Yes, there are still risks that the person might go on to develop, but the risk factors or the chances are lower. Studies state that anywhere between 10 to 20% of high risk subject may go on to develop, 80% might not develop it. We need to understand that the genetic factors play a role of susceptibility, especially in the brain network. Our brain is like a very complex electrical wiring system. We know that I'm sure that most of you have the experience that when you're building the house, the electrician comes, he has to put those pipes, he has to uh, push those wires from the exact point to the point that where he wants. Otherwise, the switches can get confused or the wire might go into some other this thing. It's a very complex work. So imagine in the brain, naturally, we have billions of neurons which have to exactly work the same way that it needs to work. And whenever there is a problem with the chemicals, whenever there is a problem with the genetic vulnerability, even a slightest change in the brain network can cause problems and also leads to gray matter loss. I've not put up the images about the brain MRI, which helps us to understand that in patients with schizophrenia, the brain is smaller, there is some amount of structural loss and all those things, but that is a function which develops over a period of time. There is also a lot of overlapping. Initially, we thought that, okay, there are certain psychiatric disorders and then there are certain genes. Probably they are very, very specific. They are not specific. And that is exactly the reason why, if you ask me during a clinical consultation or ask any psychiatrist, do you think you are sure about this? None of us are 100% sure about this, because the same genes are also implicated in bipolar disorders. The same genes might be implicated in depression, in OCD. So there is a lot of overlap. Understanding that is, we are in a very infantile stage, I should say. Understanding it might take another few years when we are able to look at the genetic morphology of a particular this thing and say, okay, this is what is going to happen. Extreme variations and involvement, like I mentioned, there is a polygenic, what we call it as characteristics that is there. So many things expresses, or like for example, we are all Indians, we have different height, we have different skin color, different hair color, different eye color, but we all identify ourselves as Indians. So similarly, there are lots of genes which might be implicated in schizophrenia, but they might actually not be related to it at all. They might have a very complex relationship with a different gene, and those two genes, if they are involved, they might be leading into certain psychiatric disorder. So for that to understand at this point in time, it's again a bit difficult. So that is the reason there are variations, there are various involvements. The evidence has been not very conclusive. And there are also limitations in the current study, because one of the criticism of any genetic or hereditary studies is because most of the studies are based in Europe and US. There are very less studies from South Asian countries. Yes, we are picking up, there are lots of genetic studies, population studies that are being done. We also know that genes play differently in different races. How it works in us might be very different in an African population. It can be very different in an European population compared to an American population. So they have a different way of expression. That is also the reason why there is a huge racial variation in the incidence and expression of schizophrenia. So the challenges and the limitations are, at this point in time, it is very, very important that we understand and take it with a pinch of salt the knowledge and the understanding that we have. It would be highly wrong if we say, okay, we have made a big stride in understanding the genetic and heritability, and there are instances, I'm sure that you all have heard of it, when people have been told, or people have told that, okay, you get this person married, everything will go off, or even saying that if you do this, things will go off. We need to understand that there is a huge limitation in our knowledge and understanding, even though we have taken a huge stride in recognizing few things, but it's not again something which is very, very implementable at this point in time. There is also a challenge and limitation in terms of research and technology. Like I just mentioned, the data from South Asian countries is minimum, which is picking up. So probably we will have a much better understanding over a period of time. I I think I should mention about a whole aspect of anti-psychiatry movement. Even now, lot of healthcare professionals and general public do not believe psychiatric disorders exist. They just say, okay, it's in the hand, it's in his mind. He is acting or she is acting. Don't do anything. Probably take them to a temple, take them to a magical healer. Uh, these these also contribute to the understanding of psychiatry in a limited way. So that is also allowing for not understanding in a much larger context, because for a really long time, funding for psychiatric disorders was very, very minimum. Again, this is not something that is linked to it. We all know that in the US, there has been a restriction in studying about gender-related aspect, de-recognition of the genders and all those things. So that takes us back many, many years because we are trying to work on something. We are trying to understand the human mind, which is one of the most complex thing, and that leads to a problem. Time constraints, this require a tremendously high amount of time, sometimes decades, for any genetic study, and lakhs of sample, and that is also a limitation. Why? Because one of the common thing that comes is medical specialty has grown so much, it has progressed so much. There's a huge amount of money that is given to healthcare. What is happening? Time is a factor. So for someone, imagine that someone who is born for a parent with schizophrenia risk, for us to understand whether this person goes on to develop schizophrenia, it might take 2 to 3 decades. So, in 2 to 3 decades is a pretty long time. So, most of the research that is happening now might not even be helpful for our generation, it might be helpful for the future generation. And ethical aspects of it, sometimes understanding the brain, blood, storing it for the future use, and all those things. These are the challenges and limitations. One of the things how we can also understand uh, where psychiatric disorders are not just functional, there is a there is an interplay of various chemicals. Is why do we have commonalities with our parents? That is because we get certain genes from them. Some of us look like one of our parent, some of us behave like one of our parent, or we might behave like one of our grandparent. So that is an indirect indicator of the genetic transmission. Again, not everything gets transmitted. Sometimes we might not have absolutely no probably characteristic of any of our parents or grandparents. And how did we have a headache, and why? Many a times, if we are stressed out, we have an headache. How does that happen? Because again, that leads to thinking, that leads to increase in the tone of the muscles, and that leads to headache. And what will happen if you're served with your favorite dish? Why do we feel happy? Because there is a dopamine that is released in the brain. And why some people behave abnormally when they are drunk? Because there is a chemical called as GABA in the alcohol that goes into the brain, makes the changes, and leads into a change in the behavior. And why do we feel fresh when we get up from sleep? Because sleep works like a mood stabilizer. It leads to consolidation of memory. And why should we question ourselves about all these things? Is to understand that there is a genetic component to all of our things, and there is also an environment that plays a role in expressing or not expressing certain things. So that is one of the basic understanding that we should all have, and looking at from a very objective perspective. What we can do, one of the things that I always tell everyone is, if there is a question, it could be about anything, it could be about genetics, it could be about heredity, it could be about medication. Please read from reliable sources. When I say reliable sources, it has been proven beyond doubt that Dr. Google is one of the worst doctor in the world. So please do not consult Dr. Google. There are certain authentic websites. You can go into what is called as PubMed, or read research articles. I'm sure that you will all know research article contains an author name, published by a medical institution or an organization, and the time of the publication will also be there in terms of the age or the year. So being aware of all these things, educating others also, identifying and empathizing with the people who have certain issues, and probably not restrict them. One of the component of genetic and heritability in schizophrenia is, many a times we do not allow them to have normal routine. That itself might be counterproductive, which increases the risk of the symptoms and poor response to treatment. Encouraging help as well as treatment seeking. Community care, what we are all doing is part of the community care. Work, education, and care also is something that we can all contribute. So, in summary, I would want to emphasize that even though we have been talking about genes and heredity for a really long time, we need to understand without any doubt that it is multifactorial in nature. So genes play a part of the role, but they do not play all the role. So, and most of the psychiatric disorders are called as disorders because we do not pinpoint, or we do not have the ability to pinpoint a particular reason. And that is also the reason why we still continue to call them as disorders. Probably when we shift into disease, we might be much more confident in talking about genes and heredity and the risk in the next population. And causation cannot be proved now. One of the common questions that we all have is, why did I have it? Or why did he have it? Why did she have it? There is no specific question of it. So I don't think we should go behind it. Genetic factors have been noted, heritability have been noted both in schizophrenia as well as mood disorders, but they are not conclusive in nature. So do not ever get into a situation where, because someone has schizophrenia, please do not get into a situation that the person should be deprived of all normal routine life events. So the answers are also dynamic, because many a times there are instances where a person, I have a couple, both have schizophrenia. They went on to have a child. The child is completely normal at this point in time. Again, it's a long duration for us to confirm, but they are completely normal parents with the child, looking after the child and doing completely normal things. And those are the things that we should encourage. And also, it is unethical for us to prevent anyone from doing anything that they deserve to do. So I will probably stop here. If there are any questions about it, because I said I will only be looking at something very generic. If there are any specific questions, I would be more than happy to get into it and then answer it. I am going through the chat box. If there are any questions, uh, I'll answer it one by one. I'll read and answer it. If there are any questions, please use the chat box. And once I finish the chat box, please also unmute and ask the question. There is a question which says that schizophrenia, it comes from a husband who was also PMI. On the other hand, if a boy is PMI, it comes from mother's side, it comes from cross genes. That is actually not something that is really proven. Many a times, like I said, depending upon the genes, if they are either dominant or not dominant, depending upon the environmental factors, depending upon various other social factors, sometimes it can happen. There is no way, because this is also one of the risk. Whenever someone develops a particular disorder in the family, we always look for pointing fingers at a particular person, saying that this happened because of you, or this happened because of him. That is something that we should not be doing. We should never be doing, because we are not sure, and that is not how genetics work. There is another question. What psychosis in simple words? Psychosis or schizophrenia is a name which is given to a particular disorder which has a combination of multiple symptoms. The most common symptoms a lot of us know about is hearing voices or hallucinations. There are different types of hallucinations. People not just hear voices, they can see images, they can taste things which are not there, they can smell things which is not there, they can feel things which is not there. So there are different types of hallucinations. They are called as visual hallucinations, gustatory hallucination, olfactory hallucinations, and tactile hallucinations. And they can have delusions, they can have speech abnormality, what we call it as formal thought disorder. They are unable to talk, they are unable to understand, they can have significant and severe behavioral problems. So there are very complex terminologies for it, but in simple terms, it is loss of touch with reality and having these hallucinations, delusions, and other behavior problems, not because of any physical condition or organic factors. People can also have psychosis because of head injury or drug abuse and all those things. Psychosis primarily means if there is no organic factor and the person has all these symptoms, then that is called as psychosis. Does the brain send, hence I'm unable to understand this question. Nirmala ma'am, that is your question. What was that question about?
You said something about the brain changes, right?
Yeah.
Size and shape of the brain changing.
Yeah.
And therefore, the size and shape of that, does the head also change? And how does it impact functionality?
No, predominantly because the skull is a fixed size. During the infant stage, we all have skull bones which are floating bones. They are not fixed, but after a few years, it gets fixed. The skull size doesn't change unless there is an injury or unless there is a fracture. But in the brain, because of it has been studied, because of various factor, a particular part of the brain can shrink, which is called as an atrophy, or a particular part of the brain can be smaller due to neurodevelopmental things. Again, there are complex explanations for it: neurodevelopmental, neurodegenerative, which we call it as, and also some amount of genetic risk has also been found. Again, I want to warn that it is not conclusive. We cannot take that because this is there, the brain is smaller. There is another question.
Does it affect Sorry. How does it affect the functionality when the brain becomes shrink? Yeah. And how do you find out how small it is, or has it become small at all?
So the functionality wise, we all know that the amount of brain that is intact is directly proportional to the functionality of the brain. If the brain, all of our brain starts shrinking after 40, because the moment the brain has reached it's like a smooth curve. It goes up, reaches the normal level, and then starts coming down. There is nothing which says that, okay, there is a stagnation of your normal brain for a really long time. It goes up and then it starts coming down. For some people, it can come down faster. Some people, it can come down slower. And that is also the reason why not everyone over 65, not everyone over 70 develop memory deficits or dementia. So it depends upon the individual factors to it. So the lesser the amount of brain matter that we have, it also compromises our thinking, cognitive function, executive function, and all those things. They are all very complex functions which are checked with various neuropsychological tests. I also shared 2-3 things that we had studied in people. So it doesn't impact in day-to-day probably routine. No one will be able to even know. When we go for a higher order evaluation, sometimes it might come up, and that is something that is not required for any person to have a normal routine.
Okay, thank you.
So I'll go for the next one. Does depression lead to psychosis over a period of time? Again, we are looking at various disorders, even though, again, this is one warning that I tell most of my patients: do not go behind the diagnosis, because the diagnosis is for the psychiatrist and the treating team to worry about. Depression is a mood disorder. Schizophrenia is a psychotic disorder. The treatment is different. The prognosis is different. Many people believe that depression leads to psychosis, anxiety leads to psychosis. Again, if the person has a severe form of depression, they might have psychotic symptoms. We call it a severe depression with psychotic symptoms. Patients with psychosis, when they develop insight, they can also develop depression. So it is not that one is leading into another. It is how they coexist, what ratio they coexist, and what are the different factors. And each and every patient is very different, very unique. There is no generalization that can happen. So they can have a multiple permutation and combination of depression and psychotic symptoms, or psychotic symptoms with mood symptoms. So I think there is one question which I've already answered: paternal grandfather and aunt. I was diagnosed with what is the next generation? Again, if I say anything, I would be wrong. because one of the thing that happens is there is a percentage. Imagine even if it is 10%, there is no way anyone can say whether the person is going to be in that 90% or in that 10%. So we all work on that factor. All of us, any one of us can develop diabetes, any one of us can develop hypertension. Does that mean that we stop eating carbohydrates? Does that mean that we stop eating salt in our diet? No. So there are factors which we have to prevent ourselves. So if there is a very high chance and then there is no requirement for the further progression, then that is something that can be discussed. And in fact, what I would suggest is whenever someone has a doubt like this, you have a mental health professional, you have a psychiatrist, you have a psychologist, have a detailed discussion about it. Because most of the times, because this is going to be a generic this thing, a specific advice might be misinterpreted. So it is always important to discuss with the mental health professional who knows you, who knows your family, who knows the dynamics within the family, because it is not just about genetics, like I said, it is also about environmental factors, social factors, substance use. What is where, including now, a lot of newer things about climate, a lot of things about pollution has come in. And very recently, we have found microplastics in the brain. So we know that there are so many factors that is going to change. And discussing a very specific aspect with your psychiatrist or psychologist would be the best thing to do it. If a person has schizophrenia along with Parkinson's, what is the best form of treatment? This is one of the common challenges that we see. Patients with Parkinson's can have schizophrenia. Patients with schizophrenia can go on to develop Parkinson's because of two factors. When we treat Parkinson's, like I said, we give a lot of dopamine, and lot of dopamine can lead to psychotic symptoms. So it can be treatment-induced psychotic symptoms. So then we have to balance how much dopamine we give and anti-dopaminergic treatment that we give. Patients who are treated for schizophrenia can have Parkinson's disease, that is called drug-induced Parkinson's, because our medications can cause rigidity, tremors, just like Parkinson's. Then we add certain things to reduce the side effect, to reduce the Parkinson's symptoms. Again, this is done in collaboration with a neurologist or a psychiatrist. If they are well versed, they can handle both the things. Up to what age we can develop, there is nothing like that. There are instances where kids as young as 5-6 years old have been diagnosed to I think 100 plus. So there is no age limit, there is no restriction at any point in time. Generally, we expect it to happen in the second decade, that is in the ages of 20. But it can happen in any time and every time. Primarily, the incidence or the percentages might be low, but it can happen at any age. There is a question about audio. We will go for it. Shubhra, please. After the
Hello.
yes. Please
Hello,
go ahead.
sir. So my question is like, earlier we used to, family members, we used to be very scared of, marrying the patient at the MI or not, etc. So it's always, I'm still in dilemma because I have a family member who is very, interested in marrying, etc. So how far, I mean, is there any study that proves that there is less chance that the patient, if gets married, the kid will not have the same, or it's still like in process of
See, the chances are very, very less, but it is not zero, it is not 100%. That is a risk that can be taken. In fact, there are studies, especially in India, which states that if patients are married, it works as a protective factor because there is an emotional support, there is a family, there is a protection, there is a monitoring. And, most of the times the treatment that we give, many a times because there is no insight, people don't take it. So if there is a family, if there is a spouse who understands it, in fact, the prognosis can be quite good. That is what studies say. And also, in terms of the emotional support, warmth, that plays a major role in releasing a lot of what is called as a pro hormones, good hormones in the brain, which helps the person to feel better. But it is not zero, it is not 100 when it comes to the progeny or the offspring having a issue. That is this thing that I have. Like I said, I have people who have been diagnosed with schizophrenia with completely normal marital life, having their child, they're taking care, they have been wonderful parents. At
Okay.
the same time, there is an instance where both of them have psychosis, and they asked, okay, should I take the risk? When we say, okay, see, there is a small possibility that it can happen. There is a particular percentage it can happen. We will leave it to you, because at the end of the day, it is the patient's and the family's responsibility to take the call. And we always advise the family to disclose before marriage, because the person has to know. They
Yeah.
need to know what is the responsibility, what are the limitations of marriage, what are the limitations of an emotional. We also know that sometimes patients with schizophrenia can be emotionally cold. They might not be able to express emotionally. All those factors are there. So people understand it, they have taken it. Sometimes, most of the times, it has worked. Sometimes it has not worked. And that is the risk that the family has to take. There is no way any person can say 100% sure, don't do it, because it is not just unethical, it is also not practical and not right.
Okay, so the last question. So you would be suggesting the parents who have already MI, if they have a kid, the kid should be monitored regularly that he or she develops or doesn't develop the.
Yeah, some amount of we need to be a bit more sensitive and observant. That is all I would say, but do not make any changes which becomes, sometimes people can be too intrusive and get into a hyper investigation mode without absolutely anything. So too much of doing some amount of thing is also equally bad, because it can be stressful, and we know that stress always worsens any psychiatric disorder. Especially schizophrenia is known to be quite bad when a person is stressed out.
Okay, thank you, sir. Thank you.
Thank you. A person with schizophrenia is more predisposed to get Parkinson's, not in terms of the biological sense, but in terms of the side effect. They can develop certain symptoms which can mimic Parkinson's. Similarly, patients with Parkinson's can have certain behavioral problems because of treatment. They are in opposite spectrum. You can take Parkinson's as this side, schizophrenia as this side. They are in a spectrum. Now we are moving from, again, this is a bit of a technical information. In psychiatry, we are moving from what is called as a categorical disorders to dimensional or dimensional classification, where we are looking at probably a continuum of psychiatric disorders rather than a watertight compartment. The next question is, again, this is something that I've answered. I might not be able to get into it. There is a question, how is schizophrenia defined? Has the definition change of time? Some psychiatrists define as a group of illness, while one defined as one single illness. What is the current definition? I think whenever we explain any psychiatric disorder, we call it as syndrome. Uh, Syndrome means that there is a combination of multiple symptoms which needs to be seen in the same person for a particular period of time. We generally take it as 1 month for schizophrenia. So if there is delusion, if there is hallucination, if there is behavioral problem, if there is loss of insight, if there is what is called as a formal thought disorder, everything, there is now ICD-11 is what we use. You all can actually go to the web, type ICD-11 browser, look into it. That is what we all use for diagnosis, and you all need to look at it rather than probably just googling those things. So it is a syndrome. It is still a single disorder but has multiple symptoms. need not have all symptoms in the same person. It can be at least few symptoms which is severe enough to make the person uh, dysfunctional. So it is not a group of illness, it's a group of symptoms, I should say. Probably, I think they might have meant like that. It is not a group of illnesses. The current definition also says the same thing. We are moving from, like I mentioned, categorical classification. We had what is called as paranoid schizophrenia, undefined schizophrenia, hebephrenic schizophrenia. Now we are moving into positive, negative, disorganized. So dimensions is what we are moving. That is one of the progressive change that is happening. There is also a classification called as DSM-5. The ICD level from the WHO and the DSM-5 from American Psychological Association, they are trying to come together because there was a lot of variation, which was becoming a lot of difficulty for practitioners. So now they are coming together. So in that sense, definition has not really changed. There is a question about remission. Okay, remission means that the person's symptoms have resolved in such a way that they are no more diagnosable. There might be some symptoms, but they cannot be diagnosed as a psychiatric disorder. Like, for example, imagine a person has a delusion or a auditory hallucination. He occasionally, once in a while, probably for a few seconds, he might hear, but it is not something that is florid, it is continuous. So that is called as remission. So we use this word. There is also a general perception that patients with schizophrenia cannot have remission. That is wrong. Patients with schizophrenia can have remission, they can have episodic course. So whenever the symptoms are so low that they are not identifiable, they are not diagnosable, that is when we call it as remission. Remission gives us an opportunity to reduce the treatment, probably reduce the frequency of follow-up, and help the patient to get into the next stage of life events. The last question is, when antipsychotics are given, dopamine is reduced, sometimes resulting in Parkinson's, and then anti-Parkinson's type of medication are added. Is it not contradictory way of dealing with the patient? Again, that's a that's something that we deal day in and day out. Medicine and psychiatry, personally, I feel is one of the wonderful field of medicine because it gives us and throws a lot of challenges which tests out the psychiatrist, because you need to balance it in such a way that you don't push the patient to Parkinson's, or you don't develop side effect at the same time, manage the symptoms. And that is why we are there for, and that's our job. And whenever these are the questions that I think all of you, whenever you go to a doctor, or if you have an opportunity, you should ask these questions, because these are quite enlightening. And this thing, and our job is to, people ask, why should I come for follow-up? Why should I come every week? Why should I come every 2 weeks? Why should I come every month, or sometimes 3 months? That is because that is the only way we can check, we can examine and know whether there is a side effect or whether there is a law effect, whether the person has remitted or not remitted. Should we do something, reduce the dose, increase the dose? And that is the only time that we get an opportunity. Otherwise, most of the times it's the family plays a major role. This is a group of family members. Studies have also proven, I want to highlight that families play a significant role in positive prognosis of any patient, specifically schizophrenia. It is a protective factor, and that is one of the unique factors in India, where we have the family. In most of the Western countries, after 18, you are the responsibility of the state. No, the family doesn't bother. Here, we have family day in and day out with the patient, supporting, giving the medication, sometimes even surreptitiously, even though that is something that is not legal, that is not ethical. Uh, Somehow we make sure that the families are there, and families help the patient. They take it as a challenge to make sure that the patient is fine. So that is one of the aspect that comes in. And it is also very important that family have as much knowledge as possible about the disorder, illness, diagnosis, and prognosis. So there is another question. When antipsychotics are reduced, albeit gradually, patient lands up with balance issues. What would be the way out for? So we use least effective dose of medication. We use, I would not say least effective dose of medication. I would say optimum dose of medication, which is something which is lesser than the dose that we use to treat an episode. Imagine someone has active symptoms. I might use 100% of the dose. If the person is remitted or partially remitted or in maintaining, I will not be using 100. Probably I might use 80, I might use 60, or I might use even 20, 30. So that is the dose that is required. How do we know it? We go on reducing it at some point in time. Again, the most important part of the treatment is family. They might say, okay, there is a problem with the behavior or there is a problem with symptoms. Then we either stop there, go up gradually and stop there. So that is how we determine the dose. That is why the observation of the family members, clinical evaluation of the patient is very, very important. Okay, handling a non-cooperative and often abusive patient has been a big challenge. Your views, I think one of the most important factor which I did not mention is we should never ever judge our patients. They are responding to the psychiatric disorder that is there in the brain. It is not intentional. It is not directed at anyone. It should not be taken personally. Any non-cooperation, any abuse, any aggression is part of the psychiatric disorder and it needs to be treated as a psychiatric disorder. Simple example, someone has a fracture of the leg, he is limping. You are never going to take a stick, hit him and say, walk properly, run properly, because we know that there is a fracture. Unfortunately, the brain fracture, I'm just using an analogy sort of thing, is not something that we can see. So we should not do there also. We need to understand, empathize, and then when we treat even non-cooperative abusive patient, they will be much cooperative. Yes, it's a long-term treatment. Probably sometimes it is a lifelong treatment, but they will be cooperative. And that is how we need to treat. A lot of times there is a physical abuse, there is coercion, there is aggression from the family also. Please try to avoid it. Would alternate therapy like Ayurveda help in treatment? There is a lot of effort in integrated treatment because 1/3 of the patients of schizophrenia might not respond to our regular treatment. There are various attempts to use. I have used for some of my patients. Again, I would not say a very dramatic change, but definitely it helps to some extent. When you're using just Ayurveda, there is no problem because the interaction between Ayurveda and allopathy is almost not there. So in that sense, if someone wants to have Ayurveda treatment, they can definitely take it. What would you suggest for non-compliance of medication? Again, that I would say is the headache of the psychiatrist. It's not your headache. You have to just go and tell the psychiatrist that my patient is not taking treatment. We will have to deal with it. There are various other methods, including injections, which can be given once in 2 weeks to once a month, and convincing the patient. There is certain therapies called as insight facilitation therapy, which helps the patient to understand their symptoms and have better insight and then take the treatment. So I think that is how we need to handle it. In a nutshell, everything that is related to illness should be treated as part of the illness. Do not get emotionally disturbed. Do not blame the patient. Do not blame yourself also, because no one is responsible for these things. These are part and parcel of any medical illness which needs to be treated. So I think I'm done with all the questions.
Yes, doctor, that's going back to the question
Yes,
of
yes.
You said syndrome of symptoms. You don't call it a group of illness.
Yeah.
This syndrome of symptoms, there must be something like the judge says clinching evidence for any case.
Right.
Similarly, do you have any clinching symptoms for schizophrenia?
I don't think so.
Like,
Primarily
example,
because
somebody doesn't have delusions or hallucinations. What do you really label as schizophrenia in this group of symptoms?
it is, like I said, if you ask me, is there one single, like for diagnosis of tuberculosis, we need to see a tubercular bacilli. So
Yes.
similarly, is there anything in schizophrenia where this person has this delusion and I am sure that this person has schizophrenia? No. The answer is no. Previously, people thought that there is a type of delusion which is impossible, which we call it as bizarre delusion, which is implausible and impossible. If it is there, that is schizophrenia. Lot of academic this thing has gone in what is called as a Snyderian first rank symptoms, second rank symptoms. If it is there, then it is called as schizophrenia. We are moving away from those things. We are looking at biological component, we are looking at dimensional component. So I would not say that okay, there is a single symptom. If that symptom is there, I'm going to confidently say that this person has schizophrenia. It is not like that.
In that sense, when you say we are moving away, psychiatry is definitely, all sciences are moving, frontiers of science itself is expanding. That means there were possibilities of wrong diagnosis, right?
I think, again, we are getting into a bit of a complex and a tricky area.
Because it bothers many family members.
I know. So,
for a second, third opinion, then they stumble upon the right one.
Right, right. So
even in this group, I know more, couple of 3-4 families at least who have gone. Then we are labeled as headhunters.
Yeah.
Doctor
No,
hunting.
I think let's look at it in two ways.
Yeah.
Because psychiatry doesn't have any particular investigation which can tell that okay, this is schizophrenia, this is depression. It all purely depends upon the psychiatrists who does the clinical evaluation, not just one sitting, multiple times, and
Right.
set a diagnosis. That also brings in a very complex aspect of, did we spend enough time? Did we give adequate amount of time for the patient and the family member to express the symptom? Did we observe adequately? If at all there was a confusion, did we investigate it? And that brings in the subjectivity of clinical diagnosis in psychiatry. Unfortunately, just like how I said, okay, there is a guideline, there is a this thing and all those things. If it is not properly evaluated clinically, there is a very high possibility of wrong diagnosis. And in psychiatry, the diagnostic stability that we call it as is very, very poor. A person with tuberculosis, pulmonary tuberculosis in India gets diagnosed with pulmonary tuberculosis, goes to US, gets diagnosed with pulmonary tuberculosis only. There is no way that they diagnose with something else. But in psychiatry, a patient goes to a particular doctor. The doctor says you have probably schizophrenia. He goes to another doctor. The doctor might say you have delusional disorder. He goes to a third doctor, and that person might say, no, you have depression with psychotic symptoms. So that is where the tricky aspect of, in fact, I would also suggest most of my patients, whenever they feel, oh, doctor, are you sure about the diagnosis? I will gladly say, please go for a second opinion. Please go for a third opinion. Because that is how we reduce the risks of wrong diagnosis. Wrong diagnosis can happen in all medical specialties. I'm not saying that it happens only in psychiatry. It happens in all medical disorders. It is not exclusive to psychiatry, but in our specialty, it puts more responsibility on the psychiatrist because
it's devastating.
Yeah. So if that is the case, again, like I say, please get there is absolutely no wrong in getting a second opinion. Absolutely no wrong in getting a third opinion. No psychiatrist will get upset because of that. Yes, there will be exceptions, but please, whenever you have doubt, go ahead with the second opinion and a third opinion.
Thank you.
Thank you, Doctor. I could now call upon Dr. Sachin Ganorkar to give the vote of thanks.
Saraswati, a small announcement from Maitri
Yeah, sure.
Since Virupaksha, Dr. Virupaksha is in Bangalore, so he's actually one of the rare combinations of biological psychiatrists, if I can say, who is also family friendly, with such a broad smile all the time that patients get well even looking at him, I think, sometimes. That is my own. So there is in the, Dr. Virupaksha, I'm taking this opportunity to announce our collaboration
Sure.
with our institution. We are planning to, rather it's a proposal to, to bring out a small manual, because he said about families, how important they are. This manual called Golden Hour in Psychiatric Treatment. Is there a golden hour in mental illness? This title came I got this like a flash of thinking while I was talking to our health secretary, because unfortunately across India, all physical emergencies are given first aid by the nurses. I came to know that nowhere, no state government does first aid, because nurses are not trained in first aid for psychiatry. Please check this again. It will be really good. And this is not only a legal, it's a legal violation of the rights, because as per the Mental Health Care Act, all of you know that Section 21.c says equal treatment should be there for physical and mental. That is one side of the story. More than that, handling psychiatric emergencies, is that the term golden hour, is it same in psychiatry emergencies as it is in physical emergencies? So when I asked Dr. Virupaksha, he said, why don't we take it and publish a small manual, a handbook for families? So with great pride and honor, I'm announcing that Maitri Face Me is going ahead with the Department of Psychiatry, of which Dr. Virupaksha is head of the department in BGS Medical College and institutions. So we hope to achieve something. It will be a family-friendly manual, but when Dr. Virupaksha said it's for families, I said the paramedics need it more than the families. The nurses, the emergency pilots, they would drive. It's their responsibility to treat the patient with dignity, as much as that of the family members, to treat them with understanding. And so this is the announcement I wanted to make. So it will be a bilingual publication, one in English and the other in Kannada. And subsequently, if you get the money, if some of you give us money, we will also do it in Hindi. So this is our plan. Thank you, Saraswati. Thank you very much, Dr. Virupaksha, for giving us this honor. Thank you.
Thank you so much.
Yeah. Over to Dr. Sachin.
Thank you, Saraswati. Thank you, Nirmala ma'am. Thank you all the esteemed audience. Thank you, Dr. Virupaksha, for your very insightful session on genetics and schizophrenia. I think my professor said that maybe we don't understand schizophrenia and other disorders. But I think if we understand the person behind these disorders, that is where the healing begins. So I think we want to sincerely thank you on your enlightening session, which focused basically that the disease was earlier understood as functional, but there is a structural change which happens, which causes a syndrome, and maybe that's how we understand it. And thank you for your excellent analysis of the genetic basis, because that is what confuses families and also leads to stigma for a lot of circumstances which are social, financial, and maybe across in the society. So we just wanted to deeply thank you for this, for integrating the genetic insight into psychiatric care. And all of us have really benefited from this session, and we thank you very much for your time. And I would hand it over again back to Saraswati for the conclusion. Thank you, Doctor.
Thank you so much. Thank you.
Thank you. I'll just share the Face Me pledge now. Yeah. We, the members of Families Alliance of Mental Illness Face Me, pledge to support one another and other families in similar situations and use language which conveys love and respect towards each other and especially towards PMI. we should strive to protect and promote the rights of the PMI as enshrined in the laws of the land. On this day, we take this pledge to work towards the vision and mission of Face Me. Thank you so much, everyone, and good night.
Thank you.